Clearly everybody here is interested and involved in treating patients with critical limb ischemia. And after COVID ends, I think we're going to see this epidemic really rise to the forefront. So the purpose of this webinar series is severalfold. Last week, we talked about practice development strategies, really identifying patients with critical limb ischemia, chronic limb-threatening ischemia, and how do we sort of triage them and get them in for appropriate care. Talking about the background that more than 50% of patients who have a major amputation never get imaging prior to that major amputation. And yet, in our experience, particularly as we treat small and smaller targets, up to 80% of patients, have underlying arterial and/or venous insufficiency. And I showed this slide last week to talk about what we're now able to do. In American Endo, we have very sophisticated, minimally invasive outpatient technologies in an environment that patients really like. That allows us to achieve success even when other people might have had failure, or even in the most complex cases, Rutherford category 6 with extensive wound loss or wounds or wound proximal to the transmetatarsal joint. We can often achieve success and/or limit amputation so you maintain a functional foot. And I don't have to go into great details here other than say this is a great lead-in to what we'll be talking about today, which is the fact that, obviously as we get more aggressive and have smaller and smaller targets for intervention, we also need to be very, very conscious of the fact that these become more complicated or more challenging procedures, potentially more complicated, but what can we do to mitigate those complications? Also, we're interventional radiologists, but this is open to all people who are vascular specialists, and we work very closely in a very generic way with vascular surgeons and cardiologists, and we encourage everybody to treat patients with critical limb ischemia. We need a lot of people doing this. I just sort of show this that shows that, certainly the outpatient, growth for these interventions is substantial, and radiologists have been very much involved in that, particularly for the infrapopliteal interventions. So, I think as radiologists, we have a unique interest in treating these complex patients with, infrapopliteal tibial occlusive disease. So again, we're doing complex things. I have on the panel with me my partner, Dr. Herman, our associate, Dr. Gallo. Dr. Gallo is going to be very active today in the conversation. We'll get Dr. Herman involved as well. And we all consider ourselves CLI experts. You can say we're amputation fighters, it's sort of a term that's been used. And we all do these very, very, really complex and sophisticated things. And today, in talking about avoiding complications, is sort of two things. One is the avoidance, and the other is the complication management. And we're not going to focus on the management today, because clearly in the course of everything we all do as healthcare professionals, we'll occasionally have some difficulties and challenges that we need to kind of figure out and work our way through. But we're going to focus today on the avoidance part. And for us, the avoidance part is really two big things. One is we're working in an outpatient environment, so we don't want to do anything that would result in clinical deterioration on table or in facility that patients who need a hospital admission. And I can tell you in our most recent facility in Clifton, for instance, and we now have two, we've done about 450 lower extremity arterial interventions. We've had 2 patients who have gone to the hospital, and that's basically just been for observation. One we're worried about flow downstream, one a groin complication. So clearly, we focus very much on preventing this need to send patients to an acute care facility. The other is preventing acute thrombotic complications that would bring patients back in the very, very short term after we've done complex interventions on smaller blood vessels. I'm going to get my colleagues to weigh in on these as we move forward. So we have about half an hour all told. So what are complication avoidance strategies? This is sort of interesting because everyone talks about complication management, but less often do I see this conversation about complication avoidance. And this consists of a number of things, and we're going to go through these very quickly. It includes optimized medical management, the idea of opening as many vessels as possible at a single setting, so you optimize the inflow and the outflow and avoid acute thrombotic complications. Dealing with dissections, but reducing the dissections, and then consequences, of course, would be treating them. Preventing embolization, how can we do that? Because as we treat these very, very atherosclerotic, vascular beds, embolization is almost ubiquitous. So how do we mitigate that? How do we control that so we don't get clinically relevant embolization? And then 2 really important things, the last 2, choice of access and choice of target vessel. And I learned many, many years ago that if you want your take-home lessons, to be effective, you kind of put them at the end where people hear in the last. So we're going to really dig in deep into that with my colleagues at the very end. Let's mention medical management. So we're treating patients with extensive atherosclerotic burden, and invariably during the course of our minimally invasive interventions, we will get some microembolic and or cholesterol emboli, and that results potentially in slow flow. So how do we prevent that? Well, all patients are fully anticoagulated. We sort of think 5,000, but general rule is 80 to 100 units per kilogram of unfractionated heparin. And all patients be on antiplatelets, preferably before the intervention, so these things are active. And that varies depending on how concerned you are about bleeding risk at the groin, whether you do it before or after. But in an ideal state, we want to make sure that we get adequate anticoagulation, antiplatelet therapy, both of which are equally effective in preventing, embolic phenomena. I'm going to mention rivaroxaban, Xarelto, because recently the Voyager trial, which we are very deeply participant in, published their data that showed that a combination of low-dose cardioprotective rivaroxaban, 2.5 milligrams twice a day, combined with aspirin, 81 in the US, 100 in Europe, which the trial was developed, has an effective primary endpoint. And clopidogrel adds nothing to that. As you can see on this slide, certainly compared to aspirin alone, the combination had a reduction in relative risk, absolute risk. And if you look at the prior data, the compensated was a 70% relative reduction combining this compared with aspirin alone. So we don't want thrombotic complications. You'll see divergence of this curve early on down here. So this supports that this may be a very effective combination to consider in your patients, even prior to referral for revascularization. The other thing that we don't do that much is that, we do occasionally get patients where we're just a little concerned about the flow pattern on table. Again, there may be microemboli. We have both surgical endovascular data that takes anywhere from 3 days to 2 weeks before the microcirculatory bed responds to an intervention and you get optimized perfusion, which is why, by the way, for the wound care docs and podiatrists we often say don't go ahead and do that, minor amp right away. Give it at least 3 days for the microcirculatory bed to open up. We have actually angiographic images that support this as well. But low molecular weight heparins, we don't use that much, has actually become a very effective tool that we can use on discharge, as opposed to sending patients to the hospital for unfractionated heparin. And you can see here, if you sort of look at this data, that you get reductions in amputation rates and reductions in reocclusion rates, as well as other really measurable phenomena. We use low molecular weight heparin. So in appropriate patients, this has been an effective tool for us to allow patients to be discharged, go home, and give time for that microcirculatory bed to respond to our intervention, respond to some spasm, the cold environment, the atherosclerotic debris that might have gone downstream, and optimize that flow bed. So I'm going to sort of get my colleagues involved here as we move forward to some of our other complication prevention or mitigation strategies. So this is a concept of multivessel revascularization. So let me ask you, Dr. Gallo, obviously we all do this every day. Here you have a patient who presents with this pattern of disease. You have occlusions anterior tibial, disease in the perineal, occlusions of the posterior tibial artery. AT reconstitutes downstream, PT not so much, no great flow to the common medial lateral plantar artery. So, as far as getting the best result and preventing acute thrombotic complications, what's your thinking in approaching this sort of case?
Well, yeah, two things. Most important thing is to try to give this patient the best opportunity, presumably if they have a wound, to heal. So we want to open as many blood vessels as possible. So first, the purpose is to open up those and get the best chance to heal. And secondly, is if one of those vessels does go down in an acute setting, we still have some perfusion to the foot. You still have 2 other vessels that can supply the foot. So it has multiple advantages, best wound healing opportunity, and potentially, if anything goes down, you still have some flow to the foot. And then these follow-up images show that, the AT and the PT were revascularized, and there's now an open dorsalis pedis artery and plantar pedal loop. So yeah, I think this would be a great result.
And obviously, a patient like this is less likely to now present with acute thrombosis and severe worsening ischemia. And, there's not a whole lot of data to this, but if you look at the Society of Vascular Surgery Vascular Quality Initiative, as you see on the right, again, with a very early separation of curves, it supports the fact that multivessel revascularization has better amputation-free survival rates. So, we're trying to practice evidence-based medicine. I think also, as Dr. Gallo alluded to, it's not just the inflow vessels, but we're very aggressive about treating that plantar pedal arch, particularly in patients with digital wounds, which is sort of unique. You're going to find that there are a lot of people who do vascular work who are hesitant to treat extensive tibial vessels and very hesitant to treat through the plantar pedal loop. And that's part of our routine practice to optimize sort of outcomes and supported by the data as you see here. Let's talk a little bit about how we perform angioplasty. So angioplasty has been around since Charles Dotter described this in 1961. And angioplasty is obviously the balloon procedure where you inflate a balloon within a blood vessel, the idea of creating a greater lumen. Charles Dotter actually thought the mechanism of angioplasty was like clay on a lead pipe. It was just sort of dispersed. But we now know that you're actually fissuring and cracking both the plaque and the less diseased wall to create a larger overall lumen, which then heals with better flow. We call that positive remodeling. But the problem is, when you do that, you're tearing the vessel wall by intent. You're intentionally causing what we call a dissection. So we've worked very diligently on optimizing angioplasty and changing what we do to modulate that dissection, so you don't end up with tears and flaps that limit flow on the table and prevent a problem. So one thing we learned is very, very slow balloon inflation. The data on this is a little bit mixed, but we certainly believe that with these long semi-compliant balloons, the scaffolding you get of the balloon while you slowly inflate is less likely to cause flow limiting tears in the blood vessel. You do want to be able to get a high pressure balloon so you completely eliminate all waste. We know that certainly inadequate balloon inflation results in a higher rate of recoil, and that means acute failure and recurrent ischemia. And of course, the correct balloon size in IVUS is intravascular ultrasound. So we're very liberal putting a little catheter down, which is an ultrasound inside the artery to actually really measure the real diameter. It turns out that our estimation of the diameter of these tibial arteries in particular is frequently wrong. And we can use a larger balloon with these techniques to get the best gain and prevent weight loss. And really at another time, we have availability of stents. And actually tomorrow, we're gonna put in the first or second below knee tack in the country on a dedicated dissection repair device for below the knee. So again, we're developing tools to treat these things when avoidance alone is insufficient.
I think if I can interrupt for 1 second there, I think that what you were pointing out in the optimized angioplasty, in order for us to have better results and longer term results, I think what's also very important about that is that it also decreases our complications. So it's not even our long-term results that's there, but it's also things that we're using, including intravascular ultrasound, because that can sometimes direct you to which atherectomy device you want to use. The reason why I say that, and it's it's getting a little bit into the complicated aspect of what to use during the procedures, but oftentimes if you see different types of plaque, you may choose a different mode of treatment. And so I think prior to that, sometimes we would use a device and we would run into certain complications, and also those tacks. Not only will they prevent late-term thrombosis, but it will also make your earlier intervention better and providing less complications.
Safer, sure. So you mentioned atherectomy, Dr. Herman. So this is the confirmed series which talks about orbital atherectomy, but we use atherectomy for those of you who don't understand the terminology. Atherectomy is basically a way of removing the plaque. Angioplasty, like we said, is fracturing or fissuring the plaque to create a little bit. Atherectomy removes, and there are many different types of atherectomy. Below the knee, in particular, we have a lot of calcified arteries, so we use orbital, which is a diamond-coated burr, 300 grit diamond burr. We use a lot of laser as well, which gets rid of any acute thrombus which might be there, as well as providing a flow channel. And the confirmed series has showed us a number of things here again to prevent complications from this technique. So, Dr. Herman, how would you address atherectomy in the modern era to optimize this?
Yeah. So I think, the one thing that you were afraid of is embolic material going downstream. Certain devices may cause that more than others, but at the same time, it's safely using a device such as the diamond-coated tip to more, for lack of a better term, to sand down that blood vessel in the right setting is actually a lot safer in decreasing your dissections and using lower inflation devices. So I'm not sure if I'm answering your question 100%, but using our tools both on the X-ray with the fluoroscope, looking at the amount of calcium that may be present in the vessel or on the vessel wall, and then using the intravascular ultrasound to determine the component of that plaque, whether it be really soft. And in case if it's really soft, then maybe laser is a better option and safer option. And utilizing all of those tools, which we have available to us, can really create a safer intervention and a better intervention.
And there's something missing from this slide. So the Confirm series, really evaluated outcomes over a slight change in technique. And you'll notice that as the technique improved, slow flow, which would be emboli, vessel closure, which would be thrombotic, and spasm were less. So what were the differences in technique? So it was using somewhat smaller devices, making fewer passes, and really moving the devices in incredibly slow fashion through the blood vessel. The tendency is that you just sort of want to zip through and create that lumen. But, I think the motto is sort of go slow to finish fast, or if you want to think about long-term outcomes, don't go fast and make the result last. So, we could have bear this in mind, and these are really very much in our head. And we work closely with the companies. Even sometimes the companies will sit there and say, whoa, slow down, take it easy a little bit. And we found that this too can prevent complications. When do we use embolic protection? So you see that device on the right, that's a filter. So when you do femoral popliteal interventions, you can actually put a filter down. But these things are costly and can cause spasm injury of their own. So I think we have limited indications. Certainly when there's long, bulky plaque or calcium, not something that we think looks friable and embologenic. Certainly if we think there might be thrombus, where laser is a very good option as well, because it can actually photoablate thrombus. And in patients where there may be only a single vessel runoff, or very compromised vascular runoff in the foot, those are great cases when we do femoral popliteal intervention, use filters. And this gives you an idea of what you can capture. There are fewer techniques when you're doing tibial intervention. You can put cuffs down, you can put a distal sheath to aspirate, but I tend to like those less because they occlude outflow and they have their own risks, which may, offset the benefits. So again, we want to focus on these two things in the remaining couple of minutes. These I think are really important. So I'm going to start this case off, and I'm going to ask Dr. Gallo to sort of weigh in. So this is actually a recent case, but it was really exemplary of two things that we focused on a lot, which I personally think are really, really important educational points. So one is choice of pedal access when doing what we call a rendezvous procedure. So rendezvous procedures are when you get a femoral, something into the artery by the hip, and then something in the artery by the foot, and you kind of connect these two. And sometimes it's easier to cross a log jam backwards from the foot, retrograde, than antegrade from the groin. So this is a patient who has a femoral occlusion. This, for those of you who don't recognize, is where the superficial femoral artery should be. This is the profunda to the thigh. So this is a flush chronic total occlusion, CTO. It reconstitutes in typical fashion above the knee, an area we call the adductor canal. The popliteal is open. And we tried to just cross. We even use this device, which has a side exiting needle to re-enter. But what you're not seeing here is not only did we fail to re-enter, you can see I'm kind of missing the target here, but we actually had some bleeding. So, we quickly moved, forward to plan B, which was let's get access to retrograde so that we can, cross this successfully and open up that blocked artery. So the plan was to get pedal access. And we have this picture down by the calf, and you see that we're missing one of the three blood vessels. So this is anterior tibial, this is perineal, this is the posterior tibial artery. So I think that the majority of people looking at this case would say, something, this artery is open. Let's work quickly. Let's get access into this artery. But I think we have a little bit different strategy here. So Dr. Gallo, based upon sort of how we've approached things, when you see this sort of pattern, you now have to, quickly deploy a retrograde access, or even more electively. What are you thinking about which vessel you may want to enter?
Well, the first thing I look at is, that posterior tibial looks very good. And it is something, you would consider sticking, but with our skill set and the ability to access occluded vessels, I think that accessing the occluded dorsalis pedis is actually safer. And the reason for that is that you maintain flow to the foot by not occluding the single vessel outflow, and you have the ability to work through an already diseased vessel. So again, that therefore protects that single vessel, or that the perineal and the posterior tibial artery, from passing a wire and catheter through it, and being able to access dorsalis pedis and advancing retrograde through that anterior tibial artery.
Right. And I think that's the key point. So if you look here, rather than go into these open vessels, we puncture the occluded vessel with ultrasound guidance. Again, this is a unique skill set there. And we're increasingly using extravascular ultrasound to help us through this. We can actually navigate wires real time with ultrasound to occluded vessels. But you see here that, and we're at no risk here of closing, puncturing, or occluding the outflow vessel. So we're not going to go do any harm here. We don't have a sheath or catheter that's going to obscure flow. Even if we punctured this artery here and we put a sheath into work, we won't see flow beyond that point. The sheath may obscure things, and we won't know if we've caused injury. And of course, it's easier to get hemostasis at the end in an artery that's already occluded. So in these cases, again, this is a very definitive strategy, which I think has been very unique to our practice in American Endo, and we're trying to disseminate to sort of take that approach. And here we've done what we call our rendezvous. We had some bleeding, so I inflated a balloon in that track. Now a catheter comes up from below. We're able to pass the wire into that antegrade catheter. And once we have through and through access complete therapy, in this case with a stent graft. And then finally, the last case what I want to show, which again is something that we've been trying to encourage, is this idea of what target should we revascularize. So the order of tibial revascularization. So we sort of start with this baseline. You can see the patient's wound there. Now I can't see the wound because there you go, over the top of the foot. So you can see the wound there. So you might think that this is anterior tibial artery, and this indeed is the anterior tibial, which is diseased. Perineal posterior tibial artery would be where the red is, are occluded. So you might think just fix that anterior tibial artery, and many people do that. And I can't say that's wrong, not necessarily. Particularly as you look downstream, that anterior tibial artery seems to go in the wound area and supply the pedal arch. And while this may not be the best example, because it's a pretty good anterior tibial artery and a very safe intervention, it does exemplify the point that we want to make, is that, if you were doing a coronary intervention, it's a very common strategy that you open up a secondary vessel before you go after the primary vessel. For instance, you have left main disease, you reconstitute the right coronary, so you have retrograde flow before you open up the left main, so you don't end up with acute MI. So this would be the analogy of that. So in this case, a strategy we like to use a lot is to go after the occluded vessel first and the pedal arch first. Now you establish two vessel runoff to the foot. You can go ahead and revascularize, in this case, the AT, without the risk of having acute thrombotic or dissection-related complication and arterial occlusion. And this you can see here, we've actually crossed the completely occluded posterior tibial artery and then fixed the anterior tibial artery as well and established two vessel outflow. But the order of target was to do the occluded posterior first before we came to the obvious target of intervention, which is the anterior tibial artery. And what do we like to call this? Protected intervention. And again, we've adopted this a little bit from the coronary world. So Dr. Herman, I know this is sort of something we've been developed. What's your decision making about when you do and don't kind of approach things this way?
So a couple of things, so in terms of the protect intervention, one thing that you really don't want to do is make anything worse. So every intervention that I start off with, I want to look at, I say, especially in the critical limb ischemia realm, I just want to go off topic for about 5 seconds there, just to, we're still performing these procedures during the COVID-19 period, because these are procedures for patients, who cannot wait, usually can't wait more than 2 to 3 weeks at most, and usually should be seen sooner. So, in our centers, we're able to see these patients with telemedicine pretty much immediately, and also get them into the centers in a safe way to treat them during this trying time period. That being said, we don't want to make anything worse. So the first thing I do, and I think Dr. Gallo alluded to it in one of the earlier cases that you showed, was specifically to make sure that you have a protected vessel before going after anything else. So in that case, I would try to access a tibial blood vessel. And, the reason why that's always safer is also because the patient's hemostasis at the end of the case is much easier. You have patients with significantly calcified groins. If you access that with a very, very small catheter, that's a simple 10-minute hold, and the patient, usually can get up within 2 hours from there, as opposed to patients with large accesses where they're treating from both groins, where patients can have bleeding issues. So that's part of my quote unquote detected intervention as well, going through these small sheaths in the pedal vessels. Did I
Right.
answer your question, or did you have something specific?
No, I think, again, we're trying to evolve the field of chronic limb-threatening ischemia interventions, and I think each of these are really, valuable points, and, I think this case actually might have been Dr. Gallo's case, and, I can't give kudos enough to my colleagues for, what they are able to do. I mean, they've advanced the science of minimally invasive intervention to be able to do some really remarkable and sophisticated things. I am in awe of what they do every day, and we want to make this obviously more common. So, we have more people who can sort of practice this way. So we have a few minutes of questions we get through this, but see, certainly my take-home message. I mean, certainly we want to provide the best outcomes and the most durable results, but avoid short-term complications. And that's particularly more important as we, treat more complex patterns of disease and more distal targets. And we do this in the outpatient setting, but I think it's also particularly important in inpatient service. In the acute care setting, we have a COVID now, so we have the same limitations that we don't want to admit patients. Hopefully some of the strategies will make a difference in your practice, but I think really important, is that obviously we have, a diverse group of people on this call, is that, together we can make a difference. And, when we discuss this internally, kind of the goals of these webinars, part of what I thought was important is that for those of you who, treat the wounds, see the patient's front line, make the referrals, the revascularization is often a bit of a black box, right? And you don't know necessarily what goes on there. And, part of certainly our goal is that you get a better and deeper understanding of not only the devices we use, the tools we use, and the strategies we use, but sort of how these come together in a comprehensive way so we can provide the best care for the patients. And I believe in many ways, differentiated care. For those of you who provide or you do vascular interventions, many of you do these things and some may not, but we want to raise the bar so that everybody is as focused on some of these things and can contribute. I mean, some of these ideas we developed and some we've adopted. But I think this, last slide shows you what we can do. I mean, even patients with the most complex wounds, with diligent intervention, avoidance of complications, managing the patient, and really what many of you on the call do in terms of the wound care in the toe and flow model becomes so important in getting the optimal results. So really, thank you everybody for that. If you want to contact us, again, this is sponsored by American Endovascular and Amputation Prevention. So here's our contact. Obviously, I think many of you who are on this call kind of know us personally, and we're always available. You can reach out to us anytime. Shout out to Rich Rosen. I see he's on there. He's a longtime friend of ours as all. I just know because he made a comment. I don't see the other panelists, but certainly all of those who were friendly with me, thank you for your support. And feel free to ask some questions now on the chat. We have another minute or so, or afterwards, if there's anything that we overlooked or just want to discuss, reach out to any one of us. And I think that we don't have here, but we have another webinar next Tuesday and the Tuesday after. I'm not sure if we take a little break, but we really have a robust series of talks coming up. I think by the end of this, everybody on this call will have a very in-depth understanding of strategies around treating patients with critical limb ischemia, really from identifying the patients right through to the post-care management. Srini says, how do I access it? I assume you're talking about the blood vessel. So
no, he was actually talking about the if there's a recording of this. I believe because I had answered a quick one. So there is a link, and I'm trying to find out exactly how that link is, and I will put that up in a moment. But the blood vessel with a needle and an ultrasound, if that was his question.
And Srini, I know you know this already. I've seen your cases. You're spectacular. So, but I will tweet tomorrow the link. All right. So if nobody else has any other questions, then thank you so much. This has really been. Wait, I see another question maybe popped up. Nope, that was a comment. All right. Yeah, thank you so much. Thank you to my colleagues. First and foremost, like I said, they motivate me every day to be a better doctor. Thank you everybody on this call. Some of you are people I have a tremendous admiration of for what you do in treating patients with critical limb ischemia, and look forward to continuing to work together, in the years to come. So everyone have a good night. Stay healthy. Stay safe.
Bye, guys.
Bye.